Today's topic includes the endoscopic diagnosis and indication for colorectal ESD and comparison between conventional EMR and ESD. And finally, I talk about how to perform colorectal ESD safely and effectively. So we are using magnification colonoscopy routinely. This endoscopy enables us to diagnose the histology accurately, just putting down this knob. As shown, the indication for endoscopic resection should be the region without the risk of lymph node metastasis. From huge database analysis, SM1 cancer, the depth of invasion is less than 1,000 micrometers from the muscularis mucosa, and without lymphovascular invasion, without poorly differential component, has very low risk of lymph node metastasis. So this kind of region, or intermucosal cancer, or SM superficial cancer, are good indication for endoscopic treatment. And endoscopy only predicts the depth of invasion. This slide shows the definition of our invasive pattern, modified Professor Kudo's PIT pattern classification. So invasive pattern is defined as irregular, distorted clipped, as observed in this kind of demarcated area, such as depression or reddened area. This region is a good example to show the utility of invasive pattern. In the left side of this region, you can see regular PIT pattern, non-invasive PIT pattern, corresponding to intermucosal region. In contrast, in the right side of this same polyp, you can observe irregular distorted clipped with in the market reddened area. This corresponding to SM deep invasive cancer. So PIT pattern well correlate with histology. And we use angiocarmine, and also when we suspect type 5 PIT, we routinely use crystal violet staining. This is a nuclear staining method, and we can get a very detailed PIT pattern. And this slide shows the diagnostic accuracy of invasive pattern. As shown, invasive pattern showing high accuracy rate, including 99.5% specificity and 85.2% sensitivity for differentiating intermucosal or SM superficial region and SM deep invasive cancer. So we are using this invasive pattern for daily practice. What is the endoscopic indication for EMR and ESD? We have reported our data in gut in 2006. As you know, laterally spreading tumor is a good indication for endoscopic treatment because LST grows laterally rather than vertically. And even if they grow more than 2 centimeters, it's a good indication for local treatment. And this LST is divided into 2 subtypes, LST granular type with aggregation of nodules, and LST non-granular type without aggregation of nodules. Importantly, this LST granular type showing lower SM invasion rate compared to LST non-granular type. And as for SM invasive area, from our histopathological and endoscopic analysis, LST granular type showing the SM invasion under the large nodule. And in contrast, in non-granular type, showing multifocal SM invasion, and this kind of multifocal invasion showing SM superficial, and it's very difficult to predict even using magnification colonoscopy. So our indication for LST granular type could be planned piecemeal resection, resecting the area including the large nodule first, and after that piecemeal. But for LST non-granular type, this kind of very flat region should be resected en bloc using ESD or other technique because of the higher SM invasion rate and also the difficulty of predicting the SM invasive area. So our indication is the SM2 cancer should be resected by surgery. So this slide shows the comparison between conventional EMR and piecemeal resection and ESD at our National Cancer Center. And all of the cases were followed up more than 6 months endoscopically and sometimes for CT examination. As shown, ESD has been treated larger regions. The mean tumor size about 3 centimeters. The maximum one was 95 millimeter compared to, I'm sorry, 4 centimeter in the ESD group, larger than 3 centimeter in EMR group. And as for the macroscopic type, ESD group included more LST non-granular type. And this is a result between EMR and ESD. As shown, ESD showing higher en bloc resection rate of 84% compared to 33% in the EMR group, and resulted in lower local recurrence rate of 2%. 2% in the ESD group compared to 14% in the EMR group. The procedure time was much higher, longer in the ESD group compared to conventional EMR. Quite recently, we experienced this kind of cases. LST granular, more than 5 centimeter, magnification endoscopy showed non-invasive pattern. So this is about 8 years ago, more than 8 years ago, I performed planned piecemeal resection, and histology revealed intermucosal cancer and without lymphovascular invasion at this moment. However, 6 months later, 1 year later, there are no local recurrence, but 2 years after, we found this kind of invasive recurrence. So we performed surgery. This is advanced invasive cancer. Probably in this case, from March fragment resection, the accurate histological diagnosis was impossible and resulted in this kind of invasive recurrence. This kind of invasive recurrence after piecemeal resection is quite very rare. However, focus on LST more than 4 centimeter, this recurrence rate raised to more than 10%. So we cannot ignore this invasive recurrence rate. So now, recently, we also expand the ESD indication not only for LST non-granular type, but also for LST granular more than 3 centimeter or more than 4 centimeter. So today is the conference with surgeon and endoscopist. So how about the comparison between LAC and ESD? But this comparison is quite ridiculous because the indication is quite different. ESD should be performed on SM deep invasive cancer with risk of lymph node metastasis, but ESD is just a local treatment. So LAC should be like a Concorde. ESD is a zero fighter, like this. The low tech technical. So as shown, the indication is quite different. How about the comparison between TAR transanal resection and the ESD? So we recently published the comparison data at our National Cancer Center. The indication is T1 cancer, and estimated as M or SM superficial. As shown, For TAR, it is difficult to perform the upper rectum cases, so 0 in RA, and this is a number in each rectum location. This is a little bit old data from 1998 to 2006. The procedure time was much longer in the ESD group compared to TAR. However, this procedure time in TAR doesn't contain the anesthesia procedure. Recently, the ESD, we have the learning curve for ESD, so mean procedure time is about 1 hour. Hospital stay, much shorter in the ESD group compared to TAR. Interestingly, the en bloc resection rate is much higher in the ESD compared to TAR. And the local recurrence rate, 0% in the ESD group, and 26% are relatively higher in the TAR group. As for the complication, there are no difference between two groups. So we speculate the higher local recurrence in the TAR group probably. Okay. Poor visualization of the tumor. ESD can treat this kind of large LSTs because we can visualize the flat elevation clearly. So we think ESD is a good alternative to TAR now. So I prepared the slide of the video, but I will skip because of the time limitation. We need this kind of various devices for safer and effective ESD technique. We can treat this kind of large lesion effectively and safely. Of course, we need the learning curve for ESD, similar to TEM. So thank you for your kind attention.
Okay.